Okay, let's dive right in. We're tackling a really specific, important topic today.
Yes, non-Falciparum malaria.
Exactly. Pulled directly from this stack of notes here, labeled Non-Falciparum Malaria Revision Notes.
Ah, the revision notes. Perfect.
So if you're working through similar stuff, or just trying to get a handle on the malaria that isn't P. falciparum, well, this deep dive is really for you.
Mm-hmm.
Our mission is to take these notes, boil them down to the absolute high-yield insights you need.
Let's kind of get the crucial nuggets without you having to wade through everything.
Exactly.
And focusing on non-Falciparum malaria is so important, isn't it? I mean, Falciparum gets the headlines for severity, and rightly so.
Right.
But overlooking Vivax, Ovale, malaria, you miss key things, different risks like relapse.
That relapse risk. Yeah.
And their global impact is significant. So they'll sort through these notes, pull out what's essential, and really why it matters for your understanding.
Perfect. Consider us your guides through these notes. Definition, causes, complications, the whole lot.
All based on the material provided.
Pulling out useful facts, memory hooks. Let's unpack it.
Sounds good. So starting with the basics. What exactly is non-Falciparum malaria, according to the notes?
It sounds simple, and the notes define it pretty clearly.
Right. It's just malaria caused by any Plasmodium species that isn't Plasmodium falciparum. Straightforward enough.
And which species are the main ones mentioned in your notes that we need to focus on?
Well, the common ones listed are Plasmodium vivax, Plasmodium ovale, and Plasmodium malaria.
Okay.
But crucially, the notes also flag Plasmodium knowlesi.
Ah, right.
It's mentioned as an emerging species in Southeast Asia. And the important thing here is, unlike the others usually, Knowlesi can cause severe malaria. It can progress rapidly, looking a lot like falciparum.
That Knowlesi point is a really key distinction. Good flag. And do the notes give geographical hotspots for these?
They do, yeah. P. vivax is widespread, but the notes highlight Central America, the Indian subcontinent. P. ovale is primarily linked to Africa. And Knowlesi, like we said, Southeast Asia. P. malaria is a bit more scattered globally, generally less common than vivax.
Got it. Distinct parasites, distinct areas.
Right.
And a really practical point your notes make, especially for anyone thinking UK context.
Let me guess. Notifiable disease.
You got it.
Yeah.
Like all malaria, it's notifiable here.
Absolutely essential to remember that. Any confirmed case, report it. Public health need to know. Critical step.
Right. Now, stepping back a bit, your notes touch on some general malaria context. It's ancient, right? Huge global impact.
Oh, absolutely. Long, devastating history. The material reminds us of the immense burden, especially in developing countries. Over half the world's population at risk. Huge economic costs, too.
Makes sense. Which puts efforts like the Rollback Malaria Partnership, mentioned briefly in the notes, into perspective.
Exactly. A major global effort. It just highlights that controlling malaria is complex, not just about tackling the deadliest form.
So we know the species, where they are. How do they actually get into us? The notes cover etiology and life cycle next. Starts with a mosquito bite.
Yeah. Precisely. It's that infected female Anopheles mosquito again. And we're talking about those non-Falciparum species. Vivax, Ovale, malaria, and Knowlesi.
And this section is where we find those classic fever patterns linked to species. It feels like a high-yield revision point from the notes.
Definitely. The notes link P. vivax and P. ovale typically to a benign tertian pattern, so fever spikes roughly every 48 hours.
Tertian, 48 hours. Vivax ovale. Got it.
And P. malariae causes benign Corton malaria, fever about every 72 hours. It's a different rhythm.
Corton, 72 hours from malaria. Okay. Now, the life cycle summary in the notes, it's quite concise. Mosquito bites, sporozoites go to the liver.
And here's where Vivax and Ovale do something different, and your notes highlight this really well. In the liver, some parasites don't just mature. Some become dormant. They form these things called hypnozoites.
The hypnozoites.
Yeah.
Yes, the notes really emphasize this. This is the big memory tip for Vivax and Ovale, isn't it? Like sleeper cells.
Exactly. That's a great way to put it. They can just sit there in the liver, dormant, for months, even years. Then reactivate later, release parasites, and bam, relapse.
Why?
Even if the initial blood infection was cleared, it's the key reason Vivax and Ovale relapse is a thing, and why they're harder to eliminate completely than, say, falciparum or malaria.
That is the defining feature. Okay, so the life cycle continues. If they mature or wake up from being hypnozoites, merozoites release into the blood.
Yep. Invade red blood cells, multiply. That causes the cyclic fever and symptoms.
Then another mosquito bites the infected person, picks up the parasite, and the whole cycle starts again.
Simple mechanism, but incredibly effective for the parasite.
Okay, so bite, liver, watch for hypnozoites with Vivaxavale. Bloodstream beat blood cells, another bite, Makes sense. Who's most at risk? Your notes list the obvious. Being in an endemic area, not protecting yourself.
Right. Not using nets or repellents properly, not taking the recommended prophylaxis, that's key. The notes also mention general high-risk groups, young kids, pregnant women, older people, those without immunity.
But the notes also detail specific traveler risk factors. This is really practical info.
It is. Factors like going to places with high humidity, temps between 20-30 Celsius during rainy seasons,
Right.
visiting rural areas, maybe staying in basic accommodation, being outdoors dusk till dawn when mosquitoes are most active. Longer trips also increase risk.
And there's that slightly odd detail mentioned, airport malaria.
Yeah, interesting though rare. It's when infected mosquitoes basically hitch a ride on planes.
Seriously?
Yeah, with people or cargo from endemic areas, and then they bite someone near the airport in a non-endemic place. A little reminder of how connected everything is.
Fascinating. Okay, so we know transmission, who's vulnerable, how does it actually cause symptoms? Pathophysiology in the notes seems pretty direct.
It is. The core idea is parasites get in the blood, head to the liver, multiply, then burst out and infect red blood cells.
Okay.
It's the multiplying within and then the rupture of those red blood cells that triggers the cyclical fever and all the associated symptoms we'll get to.
So primarily the red blood cell stage driving the main symptoms. Clear. Now, differential diagnosis. This list in your notes is quite long. What else might look like malaria?
Yeah, this is a critical section. The notes list things like typhoid, hepatitis, dengue, flu, even HIV seroconversion.
Wow.
Also meningitis or encephalitis, viral hemorrhagic fevers, leptospirosis. It's a wide range.
So the big takeaway here, the revision insight, must be that malaria is a great mimic.
Absolutely. It can look like so many other febrile illnesses, especially somewhere like the UK where doctors don't see it every day. That's why, as the notes stress later, getting that travel history is non-negotiable.
Right.
Fever plus travel to endemic area, malaria high on the list. Test promptly. Misdiagnosis can be really dangerous.
Always ask about travel. Good mnemonic. Okay, epidemiology. Where do we actually see this? Focusing on the UK context from your notes. Is it endemic here?
The notes are explicit? No, not endemic in the UK. Cases are imported, travelers returning, or immigrants from endemic areas.
And the notes gives some UK numbers. Helps put it in perspective.
They do. Roughly 1,300 to 1,800 cases a year are cited, with a small number of deaths, 2 to 11 generally. They also give specific 2019 data, 1,719 cases, 15 deaths.
Okay.
And the notes stress the vast majority, like 85.8% in 2019, and most deaths were P. falciparum from Africa. But these totals do include the non-falciparum cases.
So while falciparum is the main killer in the UK context, these other species still make up a decent chunk of the actual cases seen. The notes mention a positive global trend, though.
Yes, that's a really significant point. A 60% drop in global malaria mortality since 2000 shows the impact of control efforts.
That's huge. Okay, what about how it feels? Clinical presentation. We know the cyclical fever, but what other common symptoms are listed?
Beyond the fever, the notes list chills, sweats, bad headache, muscle aches, feeling wiped out, fatigue,
Yeah?
nausea, vomiting, and sometimes an enlarged spleen can also happen.
And let's just quickly hit those fever patterns again. Key memory hook.
Yeah.
Vivax and Ovale.
48-hour cycle,
Nert-
tertian, 72-hour cycle,
Right.
Cortin, and the notes specifically link malaria to nephrotic syndrome, remember?
Right, that kidney link with malaria. Good point. And the most important thing about Vivax-Ovale presentation.
Gotta be the relapse risk, those hypnozoates hanging out in the liver.
The sleeper cells strike again. That's the big clinical challenge for Vivax-Ovale. Symptom timing is mentioned too.
Yeah, symptoms can appear anywhere from about a week after the bite to months later. Falciparum often shows up earlier.
Okay.
Vivax and Ovale typically have a longer incubation. And the action points from the notes, can't stress these enough, get the travel history, ask about prophylaxis, did they take it properly?
Crucial details.
And if you suspect malaria even a little bit, test. Test promptly, don't wait.
Prompt testing.
Right.
Now, the notes list signs of severe disease, but they also say this is usually P. falciparum, so why is it in the non-falciparum notes?
Good question. Probably for completeness, to show the severe end of the malaria spectrum. Or maybe acknowledging that Knowlesi can be severe, or very rarely, other species might cause issues if the parasite load is incredibly high, or maybe in mixed infections.
Makes sense.
The list is pretty grim. Impaired consciousness, shortness of breath, bleeding, seizures, shock symptoms, hypovolemia, low blood sugar, kidney injury, including nephrotic syndrome, ARDS.
A very serious list. Reminds you what malaria can do, even if less likely with typical non-falciparum. Okay, suspicion's high. Investigations, what's the goal?
Rapid, accurate diagnosis, that's the aim.
Yeah.
And your notes call the gold standard microscopy, looking at thick and thin blood smears stained with Giemsa.
The expert eye identifying the parasite. What about rapid diagnostic tests, RDTs?
RDTs, they're quick antigen tests. Useful, definitely, especially where microscopy isn't easily available. But the notes position them as, well, less accurate for identifying the specific species or quantifying parasites compared to good microscopy.
And PCR.
Nucleic acid tests, like PCR. Highly sensitive, great for species ID, but often used more for confirmation or maybe research. Epidemiology, not always the first-line immediate test, though that's changing.
Okay, so recap. Gold standard, blood smear microscopy, quick field test RDT, accurate species ID confirmation, PCR. Good way to frame it. Other labs needed.
Yeah, practical stuff from the notes. Notify public health immediately. Send blood to the malaria reference lab for expert confirmation.
Right.
Also, routine bloods. Full blood count often see low platelets, maybe anemia. LFTs often abnormal. UNEs might see low sodium, high creatinine. And check blood glucose can be low, especially if severe.
And the absolutely critical point repeated here and in management, G6PD activity.
Yes, non-negotiable. Must test before giving primaquine.
Why again? Remind us.
Because primaquine, which you need for the Vivax liver stage, can cause severe hemolysis red blood cell breakdown in people with G6PD deficiency. It's a massive safety check.
Cannot overstate that G6PD link. Any other tests for sicker patients?
Yeah, if someone's really unwell, the notes list things like blood gases, blood cultures to check for other infections, clotting studies, urine and stool cultures, chest x-ray, maybe even a lumbar puncture if they have neurological signs.
Okay, got the diagnosis. How do we treat these non-falciparum types specifically?
Right. The notes indicate it's usually antimalarials like chloroquine, primaquine, or maybe atomaconiproguanil. The choice depends on where the infection likely came from and local resistance patterns.
And ACTs, artemisinin-based therapies.
They're mentioned too, primarily as the standard for drug-resistant falciparum, but they are effective against the blood stages of the other species as well.
So often different drugs than severe falciparum, which might need IV treatment like artesunate.
Yes, typically. And crucially, for P. Vivax and P. Ovale, treating the acute blood infection is only step one. You have to tackle those liver hypnozoites.
The sleeper cells, again, to prevent relapse. And that's primaquine's job.
Exactly. Primaquine is the key drug for the radical cure of Vivax and Ovale. It specifically targets and kills those dormant liver stages, usually given after clearing the blood parasites.
And that G6PD test first.
Absolutely, 100%. Confirm normal G6PD before starting primaquine. Avoid that hemolytic risk.
The notes suggest non-falciparum can often be managed outpatient. Big difference from falciparum.
Yes, that's right. Unless there are other health issues or signs of severity, which, remember, less likely with Vivax Malaria, but possible with Knowlesi, they can often be treated safely without hospital admission.
Your notes touch on drug resistance briefly, too.
Yeah, resistance monitoring is vital globally. ACTs are the go-to for resistant falciparum. The notes mention WHO pushing against oral artemisinin monotherapies to protect ACT effectiveness.
Right.
Artemisinin resistance itself is mainly in Southeast Asia currently, but the worry is if it spreads.
And one final absolutely critical note in the management section.
Yeah.
Sounds like a mantra.
Probably the most important practical takeaway for anyone revising or practicing. Always discuss malaria cases with infectious disease specialists. Follow the national guidelines, like the UK ones. Don't try and manage this alone.
Excellent advice. Straight from the source material. Prognosis, what's the outlook?
Generally, really good for non-falciparum if treated promptly and correctly. But the notes repeat, there's that relapse risk with Vivax and Ovale from the hypnozoites. That's recurrence, not reinfection.
And without treatment.
Like any malaria, it can be fatal, especially if complications develop or if it's P. Knowlesi. And the notes link those UK deaths back to lack of prophylaxis. 87% in that 2019 data didn't take preventative meds. Prevention is just so key.
Speaking of which, prevention methods listed.
Yep, the standard stuff. Chemoprophylaxis, taking the tablets, vector control insecticide-treated nets, indoor spraying, behavior avoiding bites, especially dusk till dawn. And vaccines are coming along, though mainly targeting falciparum for now.
Right. Finally, complications. The notes seem very clear which species this mainly applies to.
Yes, they state explicitly. Serious complications are mainly associated with P. falciparum.
Okay.
But they list the potential complications of malaria generally. Things like cerebral malaria, impaired consciousness, seizures, kidney failure, acidosis, low blood sugar, pulmonary edema, ARDS, severe anemia, splenic rupture, rare, clotting problems, shock, secondary bacterial infections, multi-organ failure, blackwater fever. Basically, very serious outcomes.
A sobering list, even if less likely with typical non-falciparum than falciparum. Just shows malaria needs respect.
Absolutely.
Wow. Okay, that was a really thorough run-through of your notes. We've covered the definition, causes, risks, pathophysiology, differentials, epidemiology, including the UK context.
Clinical features, those fever patterns, the hypnozoites.
Investigations, the gold standard smear, RDTs, PCR, that vital G6PD test.
Management targeting hypnovites, outpatient potential, consulting specialists.
Prognosis, prevention, and potential complications. All drawn from your source material, aiming for those high-yield takeaways.
Yeah, taking structured notes and turning them into this kind of conversation, highlighting the why it matters bits, those safety points like G6PD, it really helps it stick, I think.
Definitely. So based on this deep dive into your notes, here's a final thought for you, the listener, to mull over. Given that unique relapse risk with Vivax and Ovale from those liver stages, something falciparum doesn't have. What are the specific public health challenges for actually eliminating malaria globally? Especially in areas where Vivax and Ovale are common. Does just getting rid of falciparum mean malaria is truly gone from that region?
That's a really big question, and it underlines exactly why understanding these other malarias is so critical for global health strategy.
We really hope this deep dive into your revision notes has helped clarify things, made it more memorable, and given you a solid framework.
Yeah, I hope it was useful.
And if you did find this helpful for your revision, you might find other resources useful too. Check out PassTheMSRA.com and FreeMSRA.com for more study materials.
Best of luck with all your preparation.
Absolutely. Thanks so much for joining us for this deep dive.